Good afternoon. Hello and welcome to the latest in our series of Eno Center for Transportation webinars. Today we are discussing transportation planning and public health with Renee Autumn Ray. Renee Autumn Ray is an urban planner who has worked in transportation and public health planning, policy, operations, and data evaluation. She focuses on reducing barriers to access for vulnerable populations, including people who have low incomes or disabilities, are unbanked, or lack smartphones, and she currently leads innovation and strategy for Conduent Transportation, which is a technology company that includes payment processing, enforcement, and data analytics for transit, curbside management, road user charging, and public safety. Renee also serves on the board of directors for Georgia Bikes and on the Transportation Research Board committees for intelligent transportation systems and innovative public transport services and technologies. Today, Renee will discuss how and why urban planners, transportation professionals, and public health experts can collaborate. We will have plenty of time for questions at the end. Please feel free to enter your questions in the question box at the side of your screen at any time, and we will get to as many as possible after the presentation. With that, I will hand it over to you, Renee.
Great, thanks very much, Alice. I am very excited to be here with everyone this afternoon. Thanks for inviting me to present and share a little bit of what I've learned over the years working in transportation, public health, and healthcare. So I'm going to give you a little bit of background. Alice mentioned I'm trained, I'm an urban planner. I was actually originally focused on land use. But when I went to work for the city of Tupelo, Mississippi, under a mayor who was elected on a public health platform, that was my first foray into transportation planning. You can see a photo on the top right. We passed the first 3-foot law for pedestrian and bike safety in the state of Mississippi. We passed the first complete streets policy. You can see on the bottom right a pretty nice photo of a complete street in downtown Tupelo. From there, I was able to work directly with CDC on some major chronic disease-focused public health and built environment contracts that were passed in the wake of the Affordable Care Act and the Prevention Fund. And I've also worked for United Healthcare directly on operationalizing transportation services for vulnerable users. So I'm going to share with you a little bit about what I've learned over the course of my career and how urban planning and transportation have some pretty deep ties with health and healthcare, and how we can benefit from interdisciplinary partnerships. Certainly, urban planners, we have that foundational philosophical underpinning that we're working for the health, safety, and welfare of everyone in our community. So you're going to understand some of the basic ways that transportation and planning impact health. These include things like vehicle crashes, air pollution that might be caused by vehicle emissions. But some other really important factors include transportation access to jobs, to essential services, and also access to safe and convenient places to walk and bike. This access is how transportation is a social determinant of health, and the social determinants of health are the external conditions that describe the environment in which we live and work and play. And that environment that we move through has very direct impacts, both positive or negative, on our health risks and our health outcomes. One of the primary ways that social determinants affect us is that income is strongly associated with morbidity, our level of health and well-being, mortality, the risk of death that we have. And so every step that you move up the income ladder has macro level, more positive effects on health and longevity at a population level. And there has been some fascinating research from Raj Chetty and Nathaniel Hendren at Harvard that commute time is the single strongest factor in the odds of escaping poverty. And so when you look at all of this together, I think you can see that those of us in the planning and the transportation industry have tremendous influence over the health of our communities, because we have a role in providing and maintaining a community and a mobility system that allows people to access work, access jobs, access food and essential services, and really just live a full and a rich life with high quality of life. So I think what's top of mind for all of us right now, unfortunately, is the spread and the need to mitigate COVID-19. There are some fundamental ways in which transportation is tied to COVID-19. As an infectious disease, it's spread through coughing and sneezing. The virus can live on hard surfaces for a period of time unless they're disinfected. And so there's an inherent challenge for us as practitioners that we need to prevent the spread of an infectious disease, but at the same time, we need to continue to provide access to medical care. People that are working essential jobs need to be able to get to those jobs, and people need to continue to be able to access essential services. So COVID-19 is affecting us across all of the transportation industry, but certainly when you think about the dangers of spreading this disease, the primary ways that it's going to be spread are going to be where you have a shared space and you might be close to strangers, right? So aviation and public transit are the modes that are most affected by the spread and that also are taking the most leadership role in terms of mitigating and reducing the spread of disease. By this point, I think every major professional organization has compiled resources and best practices for how their particular industry is affected. I'm a big fan of TRB because it's the place where scientific research meets practitioners and the best practices and the most emerging research get translated into practice. So I've shared up here the TRB webpage, and there are a couple of reports specifically for these affected industries, aviation and transit. Just a note, I have links in the notes portion of these slides so that you can find all the primary sources for what I'm sharing in these slides. And these slides are going to go up on the Eno Center website shortly after this presentation. I'm going to move into 3 examples of the benefits of collaborating with health. But what I really want to impress upon you during this webinar is that if you are an urban planner or a transportation practitioner, this may be the first time that you're working with a public health agency or a health department, or it may be the first time that you're thinking deeply about how your role affects and can influence population health and public health. But I hope that it won't be the last, because there are some really strong benefits that accrue on both sides from collaborating with health practitioners in the medium and long term. So I'm going to dive into the first example now. One great way that you can collaborate is you can use individual healthcare records to better understand the built environment. USDOT has funded a longitudinal study to understand how the built environment and transportation access are related to health outcomes in heart failure patients. So this is something that Cornell University is doing through their Center for Transportation, Environment, and Community Health for mapping and larger data sources, and they're also partnering with the Weill Cornell Medical College Healthcare Policy and Research Institution to gather and analyze patient-level data. So this is a tremendous undertaking. If you have ever worked on academic research related to transportation, you should be sufficiently impressed by a sample size that is 1.5 million people's patient data. So this is an enormous sample size where Weill Cornell is taking electronic health record data from this number of patients at the tri-state region around New York. And what they're doing is geocoding and overlaying that data with individuals' home locations. And they're also mapping community level data sets related to travel behavior, presence of active transportation infrastructure, and other built environment factors such as access to fresh and healthy food. One thing I want to note here, one of the biggest benefits to working with folks in health is that a basic part of training for healthcare and public health is understanding and protecting individual privacy. whether you're talking about HIPAA data from the Health Insurance Portability and Accountability Act, or whether you're talking about PII, personally identifiable information, or PHI, protected health information. I know we've had a lot of recent controversy in parts of the transportation world with protecting individual privacy around travel behavior, and also being able to sufficiently anonymize data for that protection. And I would look to healthcare partners as folks that have expertise in that area and could be very helpful in figuring out those sorts of issues. So this project has three parts. The first two studies of this three-pronged longitudinal study it analyzes the patterns of health and healthcare utilization with travel behavior. They do that both cross-sectionally, a specific point in time. They also do it longitudinally. They measure it over time. And so some of this research has already been published. You'll see it in the notes for these slides. The third part of the research is ongoing, and that is identifying any role that social determinants have in predicting hospital readmissions for these patients with heart failure. So it gets us to a point where we might be able to predict who is most at risk for an adverse health outcome based partly on their location, and focus an intervention to prevent some of those negative health outcomes. I'm going to move into my second example now. It comes from San Francisco's Vision Zero Task Force. It is about using health records to identify and prioritize intersections for improvements. My assumption is pretty much everyone on this call is familiar with Vision Zero, the movement to eliminate all traffic deaths and severe injuries. When San Francisco was setting up their Vision Zero Task Force, they decided to have it jointly chaired by both the Municipal Transportation Agency and the Department of Public Health. And one of the primary ways that they are making data-driven decisions in their work is that they have gathered health-related records. So you can see some of the data sources they're using come from the chief medical examiner's motor vehicle monthly death report. They're getting data from the police department on fatal traffic collisions, and they're also getting information anonymized from the General Trauma Center on injuries and deaths from a major hospital in San Francisco. And so what they're able to do is take these health data, map them onto the street network, and use that to identify hotspots where they need to focus limited resources to develop policy or infrastructure solutions to be executed on to try to reduce some of those crashes. I'm biased around my third example because I came up with it. And this is one where you can use an existing health survey tool to compare a small sample size with a large one. I really like this example because I think it's great if you work for a cash-strapped public agency, which is most of them right now. And this was one where I was working for the Atlanta Regional Commission, which is both the regional planning agency and also the area agency on aging. We responded to a funding opportunity that the Federal Transit Administration put out. They wanted to fund pilot projects related to transportation interventions that might demonstrate a positive health outcome. What we decided to do was partner with MARTA, our transit agency, with the Morehouse School of Medicine, and with several local health systems such as Grady. And what we wanted to do was identify patients who had missed healthcare appointments, provide them with free transit passes, and if needed, travel training, and help enrolling in paratransit and reduced fare. So over the course of this 6-month intervention, we worked with 213 patients and a total budget of $337,000. And one thing I want to highlight in this first sentence here is the need to identify health outcomes. If you have worked with or developed key performance indicators or worked with large data sets, you understand the difficulty in identifying an outcome as opposed to just an output. If you haven't, you can think of an output as something like the number of vehicle miles traveled for a bus fleet in a month, right? Pretty straightforward. Whereas an outcome might be something like how many people have access to a transit stop within a quarter mile that has a route passing or has a vehicle passing every 15 minutes, and let's measure the change over time. So you can see the complexity in measuring this is a lot greater. And what we decided to do to measure health outcomes in this 6-month pilot, which is not a tremendous amount of time to show health, is I proposed that we use a very common tool that CDC has called the Healthy Days tool. So if you're looking at this slide, this is the entire tool. It's 4 questions. You can see how quickly you can administer it to someone, how easy it would be to update it over time. So this is something where we administered the tool to folks at the beginning of the pilot and at the end. We were able to demonstrate statistically significant outcomes. We had a number of folks whose health went from fair to good, and we also had a 40% reduction in the no-show rate of people who missed appointments. But what is really powerful about using the survey tool is the way that you can scale your data with the data that the CDC has been collecting. So this Healthy Days tool is part of some larger survey tools that have been ongoing on an annual basis since 1993 for a state-based behavioral risk factor surveillance system, and since 2003 for a healthcare-related data set. And because these data are gathered by public agencies, they're publicly available, which means if you administer this tool for your own particular sample size, you're going to be able to compare it to a much larger data set, and you'll be able to analyze it by controlling for ethnicity that matches your population, for age, for geographic area. You have tremendous opportunities to conduct analysis because of the robustness and the richness of this existing data set. So I'm going to switch now to just the slide that has some of my contact information. I mentioned that we are going to have these slides up later that have links to all the primary sources, and I'm going to pass it back to Alice so that we can move to Q&A.
Wonderful. Thank you so much, Renee. Those are some really great resources, studies, and advice for professionals, both right now at this moment and moving forward. We have a lot of great questions coming in, so I'm just gonna start fielding them towards you.
Okay.
There's a couple questions here about what people or what agencies can do at local, state, and federal levels. So you highlighted that great USDOT study, but beyond funding research and looking at what data can collect, what role do you see USDOT and then state DOTs and then maybe also local agencies playing in helping making these connections between transportation and health?
Let's see. Certainly, I would say whatever level of government you're operating at, county, state, and federal, you're going to have a counterpart in the public health realm. And so, for instance, but I would also say that it can vary. So, for instance, when I was first getting started for the city of Tupelo, Mississippi, I called the county health office to ask if they wanted to, kind of partner with me or help work on some of my initiatives. And I could tell they didn't really know why I was calling them and didn't think, that they had any role to work with me. So I then moved to working with folks at a different level of government. So, I mean, my advice would be find someone that's interested in working with you. Ideally, it's someone, a peer at the same level of government, but there are opportunities at all levels of government. I would also say one of the big benefits is being able to take advantage of grant and funding opportunities if you can cobble together two different sources of local match for larger grant opportunities, that may expand the reach of some of your programming. That was certainly something I saw when I worked with CDC. That was a period of time when there were something like 37 extensions to the DOT funding bill. And so a lot of early bike share was actually paid for with CDC money because the local community wanted to do bike share, but they couldn't get money from DOT. So they found a funding source that was available. They tapped that. And that in some ways led to partnerships that were able to continue, right? Because they worked together on one project, and then they created a relationship that sustained for additional work.
Excellent. Great advice. So you talked a lot about sort of looking into public health from the idea of being active and having benefits that way, and then also lots of other concerns in terms of access to jobs and services, as well as road safety and crashes. There's clearly a lot of elements here. A lot of these, such as air quality, pollution, distance that you have to travel, also have to do with land use patterns. So when looking at collaborations between transportation professionals, planners, and public health officials, how much of this relates to systems and access versus land use changes? And are there studies that are taking all of that into account, or plans or examples that are doing this well right now?
Let's see. I definitely agree as a land use planner that a lot of the negative externalities of poor land use and zoning decisions unfortunately fall to transportation systems and reducing access or creating more barriers to access and to shorter commutes. I think this is again one where you find the partners that are available and work with them. I would look as a good example to the state of Tennessee. They have a really incredible leader, Leslie Meehan. She used to work for the Nashville Regional Planning Office. She took a job working at the state level Department of Health, and she was able to put in an initiative where folks at local health departments could take maybe 5 to 10 hours a month and participate in some way in a local board. So you had situations where you had a planning commission adding someone with a public health focus to that decision-making board, and being able to bring a public health perspective to a group of folks that might not have been thinking about that before. So that's one of my favorite examples for bringing folks into the room that might not have already been there.
Excellent.
Does that answer your question?
No, if it didn't, the question asker can go ahead and follow up via email with your contact.
Okay.
The next question is, given the time that we're in and the COVID-19 crisis, do you have any recommendations for transportation professionals for things they can do right now at this moment to help advance the incorporation of health into their current decision-making and operations?
I'd say an example that I'm really excited about is the way that some cities are closing streets or lanes to traffic to enable more safe walking and biking routes. It's something that has been often is politically controversial, but in my mind, where you're seeing dramatically lower rates of vehicle congestion anyway, it's the quickest way to significantly scale up safe walking and biking routes and give people access where they can easily stay 6 feet apart from folks. I think it's particularly important in areas where the transit agency has switched to an extreme weather or a Sunday level of service to help folks continue to be able to get out when they need to, even if their normal transit route isn't operating as frequently as it usually does.
Excellent. Great advice. So, as we're thinking about the next generation and instilling good practice when people are young, what best practices are there out there, and what advice do you have in thinking about how to connect children and youth to transportation choices and options that have more positive and fewer negative impacts on their health?
You know, one of the things that I did when I worked in Tupelo was throw bus rodeos. So you might close a parking lot in or near a school. You would bring in maybe depending on the receptiveness of the community, police officers that might be donating free helmets, or you might have LCI trained bike instructors. But basically, um, you go into a school and have an event that sort of demonstrates that the fun of biking, but also the safety rules that kids need to follow when they bike. Um, I'm not thinking of an existing program that really works at a school district or a larger community level. Just based on my own personal networking, I have sometimes, given lectures on urban planning at, K through 12 schools and things, but I haven't really seen a good example of a larger initiative to introduce kids to, healthier forms of transportation or to planning in general. I didn't know what planning was until I'd been out of undergrad for a year or two.
I don't think that's uncommon.
Yeah.
Okay, here's an excellent question. For public health professionals who are interested in collaborating with transportation, especially highway and road authorities, when public health professionals find barriers in from the transportation side, like lack of willingness to partner or not quite seeing the benefits of partnering with public health officials, um, how do you think they can further that communication and impress the benefits upon local authorities to move those partnerships forward?
My advice, it's a little bit similar to an earlier question, which is if you try talking to two or three or four people and none of them are really receptive to what you're trying to do, just keep trying. Or think about, if the approach that you're taking, if you think about your approach and you realize that perhaps it hasn't really articulated the priorities that the person you're trying to work with has, then maybe you need to reframe what you're trying to do in a way that more clearly demonstrates the benefits to them. Um, and I would say sometimes it just doesn't work. You can't find someone that's willing to work for you. Sometimes you have to wait until a funding opportunity comes along, until the sort of, the obstacle in your path switches jobs and someone else comes into that job that might be more receptive to working with you. I would just say try different people and try different messaging to see if you can get anywhere.
Great. It can definitely be a challenge sometime from either side.
Absolutely.
Okay, I'm gonna throw a difficult one at you.
Go for it.
Given the need to address equity issues in specifically public transit and for agencies that have limited resources, from your public health perspective, what are your opinions on the coverage versus frequency decision making that transit agencies have to make?
I would say my personal opinion is frequency over coverage. My understanding is that when folks have studied what makes people receptive to or non-receptive to transit, people value their time and they really value reliability. And I think the danger of a number of routes that might only operate every 45 minutes to an hour is that you feel less confident about relying on a service, because if you miss one, you've probably ruined your trip because you're going to be late for what it is that you're going to.
All right. I'm going to go with one more question. We're already at 2:30, but there's tons of questions coming in still. So back to the current public health crisis that we're experiencing now, what do you think the main challenges are going to be moving forward after these months of limited to no transit and very limited movement? As we sort of get out of that, what are the criticisms and maybe the fallacies around public health that are going to be difficult to overcome, and how do we move forward in the most productive way possible?
I think that the main challenge to transit may be the same one that we've had previously, which is that the federal government and in general elected officials prioritize capital over operations and maintenance. And everybody wants to go to a ribbon cutting, right? And show off something new and shiny. And I'm worried that when you have sustained lack of ridership and challenges to the tax base, which could further decrease operational dollars available for transit systems, I'm worried that it's going to be very hard for them to recover from that. And yeah, I think it's going to be challenging, and I think it'll exacerbate what we saw after the Great Recession of 2008, which is we will never have as many dollars per capita to spend on people that we did before that recession. And I'm concerned that that same thing will happen. And, transit is often in line behind the roadways for that money.
All right, that is not the most optimistic view to end on, but it reminds everybody listening that we need to do our part to try to incorporate health and transportation and healthy transportation options moving forward. So thank you so much for joining us today, Renee. This was a fabulous presentation, and we will have a video of the presentation as well as the slides available on our website at the same link where our listeners were able to register. Thank you everybody for joining us this afternoon. Eno is definitely going to stay on top of all of these issues. And please stay tuned. Visit enotrans.org for further information and to sign up for Eno Transportation Weekly. Everybody stay home and stay healthy and have a good afternoon. Thanks again, Renee.
Thanks very much for having me. This was great.